Hello all. So in this lecture, we are going to discuss gastrointestinal pathology. A few questions, frequently asked questions, and also few multiple choice questions. This is a part of a 90-day university pre-final mastery program where we are going to rapidly revise all important questions and volatile facts, along with a few high-yield topics. So we can see in Auricle, we have recorded classes, live classes, practical sessions, exam modules, and also hard copy books. In recorded classes, it is very useful for flexible learning and convenient revision before the exam. Live classes cover in-depth topics and facilitates interactive learning. The express exam module covers syllabus in just 20 hours and also how exam writing skills, how to write present answer, and how to what are the frequently asked questions are going to be discussed in express exam modules. There are one-to-one doubt clearing sessions which are available. Hard copy notes which are available for all questions, including practicals. Question banks are also available. Question banks have three levels of expertise from beginner to expert level for your Proff exams as well as your DPG exams. Practical sessions are also available which facilitate hands-on experience. These are the subscription plans. For more details, you can go and visit the website. So this class is gastrointestinal pathology. We're going to go ahead and first discuss the type of gastritis. Gastritis, the first thing which we are going to discuss. Okay, so the two important types of gastritis which you have to know is the Helicobacter pylori gastritis and the autoimmune gastritis. So these are the two most important types of gastritis which you have to know. The most important difference between Helicobacter pylori gastritis and the autoimmune gastritis is Helicobacter pylori gastritis is antral predominant gastritis. What does antral predominant mean? So this is the stomach. This is how the stomach looks like, right? So, okay, here is the esophageal end. Okay, here is the esophagus, and here the esophagus is connecting to the stomach here. This is the gastroesophageal junction. Okay, this part below the gastroesophageal junction is known as the cardia of the stomach. This is known as the cardia of the stomach. Okay, and then below the cardia we have fundus, and then there is the body, and then after that what we have is the antrum. Fundus and body are almost similar. They can be used alternatively, right? So this is the fundus and body of the stomach. This is the antrum, and below the antrum we have pylorus, and the pylorus opens into the duodenum. So these are the parts of the stomach we have. Okay. So now we know antrum is somewhere over here. This is the antrum. Okay, antrum, H. pylori gastritis usually affects the antrum of the stomach. Okay, so whenever you suspect that the patient is having a H. pylori infection, the biopsy should involve a tissue from the antrum of the stomach. Okay, so this is one important point which you have to remember for H. pylori gastritis. Whereas autoimmune gastritis usually involves the body or the fundus of the stomach. Okay, it is restricted to the corpus, that is body or fundus of the stomach. Okay, and H. pylori infection in later stages, it can involve multifocal atrophic gastritis. So it can involve multiple parts of the stomach, but in earlier stages, it is usually antral predominant. Okay, so this is the main difference between autoimmune gastritis and H. pylori induced gastritis. So we know H. pylori gastritis, the etiologic factor is caused by H. pylori. What is H. pylori? H. pylori is a small comma-shaped bacterium. Comma-shaped bacterium, you can see this in this image. It is a small comma, very, very small. It is very, very small. coma-shaped bacterium. It can usually be present over here, over the mucosa. Okay, usually in the surface epithelium it is present. It does not go inside. It is always superficial, always present in the surface epithelium. So this is a coma-shaped bacterium. Okay. So what does it do? It causes chronic inflammation in the gastric mucosa. It is going to cause chronic inflammation. So when it causes chronic inflammation, what are the cells which come in chronic inflammation? From your inflammation, from your general pathology, what are the cells of chronic inflammation? We have lymphocytes, right? Lymphocytes are cells of chronic inflammation. And we have monocytes or macrophages. So Helicobacter pylori causes lymphocytic aggregation in the lamina propria. This is the lamina propria. Okay, this is the mucosa. This is the mucosa, and here is the lamina propria. So you will have lymphocytic infiltration in the lamina propria along with lymphocytic aggregates. So these things will be histopathologic features of our Helicobacter pylori infection. We know that Helicobacter pylori infection can lead to peptic ulcer disease. Okay, so we know that Helicobacter pylori. What are the few points now we know? It is a coma-shaped bacterium. It is usually present in the surface of the gastric epithelium. Okay, it is actually most commonly present in the antrum of the stomach, right? And what are the conditions which it causes? It causes peptic ulcer disease, and it also causes chronic gastritis, which we can see in biopsy. And we also saw that it is going to cause multifocal atrophic gastritis, right? Multifocal disease in advanced stages, it is going to cause multifocal atrophic. This is more of a biopsy finding. So multifocal atrophic gastritis it is going to cause, and then it can lead to gastric carcinoma, gastric adenocarcinoma, and we saw that it can lead to increased lymphocytic proliferation. So lymphoid proliferations will also increase in H. pylori. So because of that, it can lead to marked lymphomas. It can lead to a lymphoma. Malt is nothing but mucosa associated lymphoid tissue. We know stomach has a mucosa. So this is a mucosa associated lymphoid tissue. So this H. pylori infection can also lead to malt lymphoma, which is mucosa associated lymphomas. So these many conditions can be caused by this small coma-shaped bacterium in the stomach. Now, we know that the pH in stomach is extremely low. It can go up to 1 because of the presence of high HCl. Okay. So, usually we know that most of the bacterium, you must have read from your microbiology, that most of the bacterium is not going to survive in such a low pH, such a low acidic pH. Right? We know Vibrio cholerae usually in small amounts when it faces the acidic environment of the stomach, it is not going to survive in small amounts unless the quantity is very high. It's not going to survive. So most bacterium are going to die in such a low pH. But what happens with H. pylori? How is it able to survive such a low pH? Okay, usually one reason is it is in the antrum. Compared to all the parts of the stomach, antrum has a slightly lower pH. Apart from that, there is a most important virulence factor which is produced by this H. pylori, which is urease. What this urease does is it breaks urea into ammonia. Okay, and because of this, it creates a lesser acidic environment. It does not create a basic environment, but it creates a less acidic environment for it to survive in such a harsh pH condition. So it produces an enzyme known as urease, which facilitates it to survive. Now we are going to go ahead and discuss pathogenesis of H. pylori and how it causes infection. Okay, so it has two virulence factors which you have to remember. There is a protein VAC-A and CAG-A. Okay, there is a VAC-A protein and there is a CAG-A protein. Remember, CAG-A protein is important because CAG-A causes cancer. Okay, so CAG-A is the protein which is responsible for causing cancer. What does CAG-A do? CAG-A has two functions. It is going to reorganize actin filaments and it also stimulates cytokines causing inflammation. Now we know cytokines causing inflammation is there. So inflammation, first thing we will have gastric ulcer formation and gastritis leading to gastric ulcer formation. Right. So this is there. Apart from this, when there is excessive stimulation of cytokines, growth factor promoting oncogenes are also getting promoted, leading to gastric cancer. So this is how CAG-A will cause gastric cancer and gastric inflammation. So these are the two proteins, virulence factors produced by this H. pylori. What does VAC-A do? VAC-A forms a channel in the lysosomal end. So VAC, remember VAC for vacuolation. So VAC will cause vacuolation. So generates multiple large cytoplasmic vacuoles in the cell. So VAC will cause vacuolation. And this has immunosuppressive effects also. Okay. So, and because of that, see, H. pylori is very notorious. It is going to reduce the, it is going to increase the pH so it can survive by producing urease. Then it is going to produce VAC-A. What is VAC-A doing? It is going to produce these cytoplasmic vacuoles and alter the T cell functions, which are natural immunity for us. So it suppresses natural immunity so that nobody comes and disturbs H. pylori. So it reduces immunity over here. So remember VAC for vacuolation. Sometimes even the tumor cells, we know there is tumor immunity also. Whenever there is tumor cells, our immunity can act against these tumor cells. That is known as tumor immunity. So when there is natural reduced immunity, so it's not going to act against H. pylori or even the tumor cells. So this is what is going to happen. Okay, so remember CAG for cancer and VAC for vacuolation and reduced immunity. CAG for ulcer formation as well as gastric cancer formation. Okay, so this is so much for H. pylori gastritis. Now we're going to discuss the second type of gastritis, important, which is autoimmune atrophic gastritis. As the name says, we know it is an autoimmune condition. Autoimmune atrophic gastritis. So autoimmune condition. What are these antibodies going to destroy? They're going to destroy the parietal cells in the stomach. We know that there are two types of important cells which are present in the stomach, right? One is parietal cells and the other type of cells are oxyntic cells or chief cells. What is the function of parietal cells? The function of parietal cells is production of intrinsic factor. What does intrinsic factor do? The function of intrinsic factor is to bind to B12. Okay. Intrinsic factor binds to B12 until it goes to the ileum for absorption. Usually we know that B12 is absorbed in the ileum. So intrinsic factor when bind to the B12, this complex alone goes and absorbs to the ileum. So B12 alone will not be able to get absorbed. So intrinsic factor plays a very important role in B12 absorption. What is the function of oxyntic cells or chief cells? It is to produce hydrochloric acid. So this is the function of oxyntic cells or chief cells. Okay, so this is what is happening. Now, parietal cells are getting destroyed by these autoantibodies. When these parietal cells are getting destroyed, what will happen? Intrinsic factor is not there because parietal cells are not there and B12 binding is not happening. There is impaired B12 absorption. If there is impaired B12 absorption, there is decreased B12 in the serum leading to deficient B12. So B12 deficiency, we know B12 and folate deficiency are going to lead to a specific type of anemia, which is megaloblastic anemia. So autoimmune destruction of parietal cells causing megaloblastic anemia is what is known as pernicious anemia. Okay, so this is known as pernicious anemia. Now, this condition also has achlorhydria. Why does it have achlorhydria? I'll tell you why it has achlorhydria. First of all, we know that parietal cells are getting destroyed, right? So, in the antrum, we have two types of cells, which are parietal cells and oxyntic cells. So, because of this autoimmune destruction, you can see here, there is lots of lymphocytes. And here there is some pinkish deposition, which is nothing but fibrosis. Can you see any cells here? Parietal cells, chief cells. So the body lacks parietal cells and chief cells. So there is less oxyntic cells. Somehow, while destroying parietal cells, hand in hand, it's going to destroy oxyntic cells also. So there is reduced HCl production. Okay, because of reduced HCl production, what is going to happen is G cells we know are producing gastrin. Gastrin, what will gastrin do? Gastrin is going to increase the HCl production by stimulating oxyntic cells. Right? So here HCl is less. So we are going to need more gastrin. So there is a negative feedback mechanism or a positive feedback mechanism in this case, which assumes there is less HCl here and we have to get more gastrin. So what happens as a result? G cells are going to produce more gastrin. And here no oxyntic cells are there to produce HCl. So what is going to happen as a result? Hypergastrinemia, more gastrin production and low HCl, which is known as achlorhydria. Okay, hypergastrinemia and achlorhydria is present in which condition? It is present in autoimmune gastritis. Now we know why it is present in autoimmune gastritis. Okay, so this is what happens. So you have to remember that even autoimmune gastritis may lead to gastric carcinoma. Apart from that, it can also lead to neuroendocrine tumors because what happens is, as a result, there is proliferation of neuroendocrine cells also. So it may lead to neuroendocrine tumor. Two types of cancers associated with autoimmune gastritis: gastric cancer and neuroendocrine tumor. Two types of tumor associated with H. pylori: lymphoma and gastric adenocarcinoma. Okay, so this is the pathophysiology of autoimmune gastritis. Here we can see the histology. There is fibrosis. Many lymphoid aggregates are present. Okay. Now we are going to discuss another question. This is also very important. This is celiac disease. Celiac disease, the other name of celiac disease is gluten sensitive enteropathy. Other name of celiac disease is gluten sensitive enteropathy. You know that this name is far better than celiac disease, right? So because this helps us understand the pathophysiology also. Gluten sensitive enteropathy. The enterocytes are sensitive to gluten. So whenever you eat a gluten rich diet, what are the foods which have gluten? So wheat, right? Wheat has most amount of gluten. So when you have a diet rich in wheat, gluten from the diet is going to come in, right? Come in and it is going to produce something known as gliadin. These gliadin are going to come in and these gliadin are what are sensitive in these patients. Why is this gliadin sensitive? These patients are HLA dependent patients. So they have mutation in HLA DQ2 and DQ8. So they recognize this gliadin and they recognize gliadin and in turn they produce cytokines, and these cytokines produce more B cells and T cells, especially cytotoxic T cells. The cytotoxic T cells are going to go and destroy the enterocytes which have these gliadin. So that is why you have enterocyte destruction in this patients. Also, you have something, these T cells will go and deposit in the enterocytes. These are known as, you can see here, the T cells are present within the enterocytes. Usually, in normal patients, you will have very few lymphocytes in the epithelium. Okay, so there are very few lymphocytes in the epithelium, but in celiac disease, you will see lots of lymphocytes in the epithelium. So these are known as intraepithelial lymphocytes, which are present in celiac disease. Also, you have to remember these three antibodies which are associated with celiac disease. One is, we know gliadin is there, gliadin is reactive, so anti-gliadin antibodies will be formed. Other than that, anti-endomysial antibodies are also going to be formed. And tissue transglutaminase, which is produced as an intermediate, those antibodies are also going to be formed. So three antibodies are going to be formed: anti-gliadin, anti-endomysial antibodies, and anti-tissue transglutaminase antibodies are going to be formed. Okay, so this is an autoimmune condition, HLA associated condition, which HLA-DQ2 and DQ8 are associated with celiac disease. So now we are going to see what are the histologic features. There is enterocyte destruction. So we know small intestine has the largest villi. We can see this is a healthy villi. Okay, healthy villi which is protruding outside. But this is celiac disease. We can see there is villus blunting. This is villus blunting. There is villus blunting here. And you can see how many lymphocytes are there inside this epithelium. In this picture, you can see so many lymphocytes are there. Whereas in the normal, there are very few intraepithelial lymphocytes which are present. So first feature is villus blunting. Okay. First, very visible, but the first which is actually present in early stages is intraepithelial lymphocytes. Okay. Third important feature which is present in celiac disease is crypt elongation. These are the crypts, wherever the villus ends. So these areas are the crypts. You can see the crypts are very flat over here. But here you can see that there is elongation of crypts and hyperplasia. Crypt elongation, hyperplasia. So these are the some features of celiac disease. Gluten insensitivity, gluten-rich food the patient is eating, and then if the patient eats gluten-rich food, then gliadin is produced, and antibodies to gliadin, they will damage the enterocytes. Antibodies to transglutaminase can also be produced, and anti-endomysial antibodies can also be produced. Okay, this is a HLA-related condition, which HLA-DQ2 and DQ8-related condition. What are the histologic features which you can see? Increase intraepithelial lymphocytes, villus blunting, and crypt elongation. Okay, so these are the features of celiac disease which you have to remember. Now we are going to discuss inflammatory bowel disease. Two important inflammatory bowel disease you have to know is ulcerative colitis and Crohn's disease. Ulcerative colitis and Crohn's disease. We just discussed differences between ulcerative colitis and Crohn's disease. First of all, remember ulcerative colitis is a disease which involves throughout the bowel. Okay, this is the right side. This is the appendix. Okay, and this is the sigmoid colon and the rectum. Usually, sigmorectoid involvement is seen in ulcerative colitis, and it is continuous involvement. Continuously, this is involved. Usually in colon, we can see some horse tray, right? So what happens is the horse tray is kind of lost here. This will lead to a lead pipe kind of appearance. Throughout involvement is there in ulcerative colitis, usually in the rectosigmoid area, rectosigmoid region. But in Crohn's disease, what is going to happen is Crohn's disease has a very patchy or focal involvement. So this is known as skip lesions. It does not necessarily just involve the large intestine. It can involve the oral cavity. It can cause anal fissures and anal fistulas also. This is for Crohn's disease. Second thing which you have to remember is ulcerative colitis actually does not have a transmural involvement. Okay, ulcerative colitis does not have a transmural involvement. What is transmural involvement? We have a mucosa, we have a submucosa, we have a muscularis, and we have a serosa. So when the disease involves through and through all the four layers, then it is called as transmural involvement. Ulcerative colitis has a very superficial involvement, so it can cause pseudo polyps. Okay, but Crohn's disease has transmural involvement. Because Crohn's disease has transmural involvement, what will happen? Crohn's disease can cause fissures, fistulas, okay, because it's transmural, right? Can also cause perforation. Okay, this is for Crohn's disease. And then another thing about ulcerative colitis is ulcerative colitis usually does not have granulomas. But Crohn's disease has granulomas. Okay. And another thing, ulcerative colitis, another major difference is fissures, fistulas, we know is seen in Crohn's disease, but it is not seen in ulcerative colitis. Okay. Another important thing is extraintestinal manifestations. Extraintestinal manifestations are very much common in ulcerative colitis. Extraintestinal manifestations are going to be common in ulcerative colitis. What are the commonest extraintestinal manifestations seen in ulcerative colitis? This primary sclerosing cholangitis, which can be seen in ulcerative colitis. But in Crohn's disease, you can see a variety of extraintestinal manifestations. Even though it is rare, you can see a few extraintestinal manifestations. Like it is also associated with celiac disease. It's also associated with ankylosing spondylitis. So, two important features which you can notice is celiac disease and ankylosing spondylitis. Both of them are HLA associated diseases. Celiac diseases associated with HLA DQ and DR. Ankylosing spondylitis is associated with HLA B27. Okay, so these both are HLA associated diseases. These are some common features which you can see. Now let's discuss complications. Complications of ulcerative colitis and Crohn's disease. Both ulcerative colitis and Crohn's disease will lead to malignancy. Okay, malignancy is a very important complication of both ulcerative colitis and Crohn's disease. But ulcerative colitis can lead to malignancy a little bit more because it has a through and through complete this thing. It has a pancolitis kind of appearance, right? As we discussed. It is not skip lesions, and it does not. Crohn's disease can involve small intestine. Crohn's disease can cause ulcers in the mouth. Okay, it has variable presentation, but ulcerative colitis involves rectosigmoid region, so it is going to involve the colon. So when we talk about colonic malignancy, ulcerative colitis has a slightly more risk when compared to Crohn's disease. Okay, and then complications. A few complications. Ulcerative colitis can cause toxic megacolon. Okay, this is the colon extends, dilates very much, and it is filled with air. Okay, this is what is called as toxic megacolon. Usually there is superimposed infection in these cases. Crohn's disease, as we discussed, it can cause fissures, fistulas, and perforation. Okay, fissures, fistulas, and perforation. It can cause, and it can also cause We saw granulomas it can cause. Okay. And about the gross appearance, these are all microscopic appearances. We know this transmural and everything. Okay, just remember transmural crowns. That will solve most of your fissures, fistula, and your anal fissures. If they ask in which condition, it's going to be Crohn's disease, pseudopolyp, ulcerative colitis. Okay, gross feature we know ulcerative colitis will have a lead pipe-like appearance because of loss of this costa present in the involved area. So it will be kind of straight in appearance. So that is the lead pipe appearance in the involved area. Grossly in Crohn's disease, we can see a few features. Gross of Crohn's disease. First feature is what is known as cobblestone appearance. Okay. Usually what happens is the stomach lining looks something like this. There is a slight enfolding and it is like this. But in Crohn's disease, it becomes something like a cobblestone appearance. It becomes very hard and round. You know the cobblestone, it's arranged side by side, right? It becomes something like that in Crohn's disease. So this is one cobblestone in appearance. The second important gross appearance is creeping fat appearance. Usually, the intestine looks something like this. These are the gastric, and there is Centertenia coli, which is present in the colon. Okay, and then here we can see a few fat. Okay, mesenteric fat will be attached somewhere over here. But in Crohn's disease, this fat extends so much so that it creeps all over this intestinal area, whereas it should be just this much. So this is known as a creeping fat appearance in the Crohn's disease. Okay, so we have cobblestone appearance and creeping fat appearance in Crohn's disease. These are for ulcerative colitis and Crohn's disease. Now we are going to discuss a few multiple choice questions. The first question is a 30-year-old male who presented with heartburns and dyspepsia. Breath test and biopsy were ordered to confirm the diagnosis. Now they've asked that what is the pathophysiology of this condition and what is the basis of the breath test and what are the biopsy findings of this condition. So we know this heartburns and dyspepsia, we're talking about a H. pylori infection here. Okay. So what is H. pylori infection? We know what is the pathophysiology. It is going to cause inflammation. You know how it is going to cause inflammation by using the two important virulence factors, SWAC and CAG. There is going to be inflammation, and because of inflammation, you will have peptic ulcer disease and also may result in gastric carcinoma. Now, what is the basis of urea breath test? We know why urea breath test is done. The breath test is nothing but urea breath test. Urea breath test is under the principle that H. pylori is producing this enzyme which is known as urease. Okay. Now, this is how the urea breath test. Urease is produced by this H. pylori. Okay. There is carbon, radioactive carbon, which is there in the bloodstream. And now this is going to get converted into carbon dioxide. And this marked carbon dioxide is going to be measured in the urea breath test. When this urea breath test comes out to be positive, it will be something red in color because ammonium is combined with this carbon dioxide and it gives this color. If there is no color, then this is negative. So this is how the urea breath test works. Okay. What are the biopsy findings? We know the biopsy findings. Biopsy findings, we will see small, slender, comma-shaped bacteria, which are H. pylori. And what else are we going to see? Where will we see? The superficially seen. And what kind of infiltrates will we see? Lymphocytic infiltrates will we see? Lymphocyte aggregates we will see. Where will we see? In the lamina propria. Okay. So these are the biopsy findings of this condition. Now, some case-based MCQs we are going to discuss. 34-year-old female with a history of Crohn's disease presents with abdominal pain and weight loss and diarrhea. So, imaging reveals a stricture in the terminal area. Okay, so we know stricture is also a complication of Crohn's disease because stricture has to form with all 4 layers constricting together to form a stricture, which will ultimately result in obstruction. So, that is also a feature of Crohn's disease. What is the most likely complication of Crohn's disease that she is experiencing? So you know that these 4 layers are there. Okay, we have things. So this has constricted, and they are forming a block over here. So whenever there is a block, what complication will be there? Intestinal obstruction. So whenever stricture is there, we will have intestinal obstruction. Next one. Which of the following antibodies is commonly elevated in patients with celiac disease? We saw 3 antibodies which were commonly elevated in patients with celiac disease. First one is anti-gliadin antibodies. And then we had anti-endomysial antibodies. And then we had tissue transglutaminase, anti-tissue transglutaminase antibody. So, among this is the answer. Okay. Anti-DNA and anti-nuclear antibodies are seen in systemic lupus erythematosus. Anti-cardiolipin antibodies are seen in a syndrome which is known as anti-phospholipid antibody syndrome. Okay. So, this is anti-tissue transglutaminase. Next one, which type of gastritis is associated with pernicious anemia? We just discussed this very easy question. Atrophic gastritis is associated with pernicious anemia. Next one, which extraintestinal manifestation is commonly associated with Crohn's disease? We saw ankylosing spondylitis and celiac disease was associated with Crohn's disease. This was HLA associated. Which extraintestinal manifestation is commonly associated with ulcerative colitis? It is primary sclerosing cholangitis. Primary sclerosing cholangitis is associated with ulcerative colitis. Okay, the next question. In patients with chronic Helicobacter pylori infection, which of the following histopathologic findings is described in the gastric mucosa? Okay, so we just discussed this. Lymphoid aggregates in the lamina propria are seen in Helicobacter pylori infection. Ascitic granuloma, we know TB. Villus atrophy, we know celiac disease. Crypt abscess is something which is seen in inflammatory bowel diseases. It can be seen in ulcerative colitis and also Crohn's disease. Crypts are nothing but which are present in the intestine, and inside the crypts you will have lots of neutrophils. So that is what crypt abscess is. Crypt abscess can be seen in ulcerative colitis and Crohn's disease when it is in the early stages or if there is an active infection. So that is when you are going to see neutrophils. No, otherwise you will see lymphocytes. So this is the answer. The answer for this question is lymphoid aggregates in the lamina propria. So thank you for watching. That's it for today's class. We'll meet you in the next session of gastrointestinal pathology tomorrow. Thank you.